We are live.
Okay. So good evening, postgraduates, and my pranam to all the mentors and the teachers who have been attending it and to the mentors today present. Welcome to this 69th episode of All India Postgraduate Teaching Program, an initiative from ARC-AFS. We say and we boast that this PG program is a slightly different cover compared to other PG teaching programs because in this particular PG teaching program of ARC, we cover the uncovered aspects of PG teachings like case presentations, the journal clubs, the OS case, and rarely do we have didactics on topics which are really not comprehensively available for them at a single go in a textbook. Last episode, we had two short cases on cornea. Today, we are into our 69th episode of the series, and this is the 14th journal club since we took over. And today's journal club would be presented by Dr. Raja Mathangi, who is a junior resident in Department of Ophthalmology, All India Institute of Medical Sciences, Bhopal, and Dr. Gahan Reddy, who is a junior resident in Department of Ophthalmology, Guru Nanak Eye Hospital, Delhi. I'm thankful to mentor Dr. Bhavna Sharma, Professor and Head, Department of Ophthalmology, Dean Examinations at AIMS Bhopal, and Dr. Pranita Sai, Assistant Professor, Guru Nanak Eye Hospital, Delhi. My sincere most thanks goes to all the discussants, senior discussants who have made time for this postgraduate program. Dr. Himanshu Matalia, who is a Medical Superintendent, Head of Cornea and Refractive and Ocular Surface at Narayan Netralaya 2, Bangalore. Dr. K.V. Satyamurthy, who is a Senior Consultant, Head Department of Cornea and Refractive Surgery at M.M. Joshi Eye Hospital, Hubli. And my mentor as well as my teacher, Dr. Srinivas K. Rao from Shankar Netralaya, who is right now Director at Darshan Eye Clinic and Surgical Center, Chennai. I'm extremely thankful to the senior consultants, senior discussants, as well as mentors for sparing time for this, our very beloved postgraduate teaching program. Now, without much ado, can I request our ARC member, Dr. Deepak Mishra, to take forward this program? And also, meanwhile, request Dr. Raja Mathangi to share her screen. Deepak, over to you.
Thank you, sir. Our first general club is on the collagen cross-linking with riboflavin in ultrathin corneas. It is a sub 400 protocol, and it will be presented by Dr. Raja Mathangi under the able guidance of Professor Bhavna Sharma ma'am. Dr. Mathangi, please start.
A warm good evening to everyone. I'm here to present an article. Sir, is my screen running?
It's visible means on the first.
I'm here to present an article published in the American Journal of Ophthalmology. The title of the article is Individualized Corneal Cross-Linking with Riboflavin and UVA in Ultrathin Corneas, the Sub-400 Protocol, authored by Dr. Farad Hafizi, Sabin Kling, among others. Introduction. CXL has been a major development in the management of progressive keratoconus. This treatment is targeted to create covalent bonds between high molecular weight polymers of collagen through reactive oxygen species without damaging the endothelium. The standard Dresden protocol applies for corneas with minimal stromal thickness of 400 microns. However, in 25% of keratoconic corneas, the central corneal thickness is less than 400 microns at presentation. Currently, many corneas with advanced keratoconus is less likely to benefit from CXL are not treated from the standard Dresden protocol because of less than 400 micron of stromal thickness. To overcome the challenge of protecting the endothelium, the following changes in the CXL have been propagated, which include increasing the stromal thickness, altering the riboflavin concentration, and epithelial on CXL. However, the results have been highly unpredictable. This study by Hafizi et al. Aimed to use the standard CXL settings with riboflavin 0.1% along with the variable irradiation time to broaden the range of indications of CXL and decrease the need for corneal transplantations. The purpose of the study was to determine whether corneal cross-linking with individualized fluents is able to stop keratoconus progression in ultra-thin corneas at 12 months follow-up. It was a retrospective intervention case series conducted between May 2016 to December 2018 at ELISA Institute, Zurich, Switzerland. Methods. The inclusion criteria were progressive ectasia, that is increase in the anterior keratometry of more than 1 diopter within the last 12 months, corneal stromal thickness of less than 400 microns, and primary ectasia in the age group of 9 to 19 years. The following individuals were excluded from the study: history of more than 10 pack years of tobacco smoking, pregnant and lactating females, history of recent ocular trauma or previous ocular surgery, and unable to understand the purpose of the study and or to give consent. The parameters assessed include preoperative, corrected distant visual acuity, refraction, and biomicroscopy. The topographic parameters included thinnest stromal thickness, anterior radius of curvature in the central 3 mm of the cornea, and Kmax. Intraoperatively, ultrasound pachymetry was done, 10 measurements were taken, and the lowest thickness was considered. Post-operatively, the same parameters that were assessed in the pre-operative was also assessed, which included corrected distant visual acuity, refraction, biomicroscopy, along with topographic parameters, and the ASOCT parameters that were assessed included demarcation line depth at 1 month and densitometry at 12 months. Method: the epithelium was removed in the central 9 mm of the cornea. The corneal stroma was stoked with sodium edetate and prometamol enriched riboflavin 5-phosphate 0.1% hypotonic solution for 20 minutes. Ultrasound pachymetry was done every 5 minutes and at the end of installation of the dye. CXL was performed with the standard parameters. However, the treatment duration was modified, aiming to keep the demarcation line depth at 70 microns above the endothelium. The table shows the parameters and the specifications used in the protocol. The following formula was used to derive the demarcation. The following formula was used to derive the UV irradiation time, and the authors have given a nomogram of UV irradiation duration applicable for corneas as thin as 200 microns up to 400 microns. The statistical analysis was performed using the IBM SPSS statistics. Shapiro-Wilk test was used to test all variables for normality. The normally distributed variables were analyzed by t-test, and the abnormally distributed data was analyzed by Wilcoxon sign rank test. Analysis was performed with a confidence interval of 95%. Pearson and Spearman correlation tests were performed for normally and abnormally distributed variables. Correlations were considered significant at less than or equal to 0.05 level. Results pertaining to the demography: the mean age of distribution was 29.16 plus minus 10.1 years, ranging between 13 to 55 years. 8 eyes were from patients between 13 to 20 years, 14 were from patients between 21 to 30, 11 eyes were from patients between 31 to 40 years, and it is worth noting that 6 eyes were from patients above 40 years of age. 34 eyes out of 39 eyes had progressive ectasia, and 5 eyes had primary ectasia. Results pertaining to the corrected distant visual acuity, spherical and the cylindrical power. The mean corrected distant visual acuity at baseline was 0.39 plus minus 0.22 logmor units. At 12 months post-op, it was 0.41 plus minus 0.25 logmar. The spherical power at baseline varied between minus 4.9 plus minus 5.44 diopters, and at 12-month post-op, it was between minus 4.07 plus minus 6.02 diopters. The cylindrical power varied between minus 4 at baseline and between minus 4 plus minus 2.82 at 1 year. No significant changes were found in the corrected distant visual acuity, the spherical or the cylindrical powers. No eyes showed signs of endothelial decompensation clinically. Results pertaining to the demarcation line: the distance from the demarcation line to the anterior stroma was ranging between 126 to 385 microns, and from demarcation line to the endothelium was between 0 to 250 microns. Significant correlation was found between the demarcation line depth and irradiation time. Considerable standard deviations in the demarcation line depth across patients of similar irradiation times were noted. In most cases, the distance from the demarcation line to the epithelium was larger than anticipated. Results pertaining to the topography: intraoperative minimum ultrasound pachy noted was between 214 to 398 microns, and 19 eyes were between 351 to 400 microns. Significant change from baseline at 12 months was noted in the thickness minimum and Kmax. However, no difference in the anterior radius of curvature in the central 3 mm of cornea was noted. Kmax remained stable, less than 1 diopter change, or improved at 1 year after CXL in 35 of the 39 eyes. No correlation was found between preoperative corneal thickness and post-op Kmax flattening. However, 4 eyes from 3 patients showed progression in the form of change in the Kmax consistent with treatment failure and continued progression. All the 4 eyes were highly progressive before CXL. 2 of them were found in 42-year female with hypothyroidism. Results pertaining to the densitometry: significant increase from the baseline at 12 months in the anterior density was noted. Although a significant increase in the densitometry was observed as expected, all the patients remained within the typical clinical pattern of mild opacity after CXL. No patient had deep stromal haze or scarring in the evaluated period. Conclusion: the sub 400 individualized fluence CXL protocol standardizes the treatment in ultrathin corneas and halted the keratoconus progression with a success rate of 90% at 12 months. It allowed for the treatment of corneas as thin as 214 microns. The DL depth did not predict treatment outcome. The DL depth, according to the authors, it was not related to the extent of CXL-induced corneal stiffening, but rather to the extent of CXL-induced microstructural changes and wound healing. No clinical signs of endothelial decompensation was noted. Now, moving on to the limitations, it was a retrospective case series with a very small sample size. 15% of the eyes were 15% of the eyes were from patients aged more than 40 years, which were less likely to progress naturally. High risk factors like family history of keratoconus, history of atopicity, and history of VKC have not been considered. Presumption that all patients between 9 to 19 years of age needed treatment, irrespective of the progression status, has given a biased outcome. The role of chemical enhancers like sodium edetate and trometamol in epithelium of protocol is unclear. It did not evaluate the failure to evaluate the endothelial density objectively with specular microscopy is a limitation. The demarcation line depth demonstrated considerable variability, and it was premature to assume that demarcation line depth did not correlate with the outcome. In spite of arrest of progression, no significant change in the corrected distant visual acuity and refraction was noted. Prospective randomized controlled study comparing hydroxypromethyl cellulose versus hypotonic riboflavin could have given better outcomes. Conclusion: adaptive fluence may be the way forward for keratoconic corneas with less than 400 microns stromal thickness. However, prospective clinical trials with larger sample size and in homogeneous group is required to validate the study findings. So,
Thank you, Dr. Mathangi, for the wonderful summarization of the article. Our experts, Satyamurthy, sir.
Deepak,
Yes, ma'am.
can I just summarize what just
Yes.
Madangi presented, and then we can go on for the expert comments?
Yes, ma'am. Yes, ma'am. You can
Yes.
summarize. Then
So yes,
can
with the
go.
permission of all the discussants, some centers would have collagen cross-linking, others might not have. Just to summarize for all the PGs about the collagen cross-linking, that it has been mainly a pioneering advancement in treatment of keratoconus in adolescent age group. And the components are the photosensitizer, that is the riboflavin dye, a UVA light source, and the resulting is a photochemical reaction. So collagen cross-linking, it creates covalent bonds, which are mediated by reactive oxygen species. But while doing this, it is reassuring that though we are irradiating the cornea with the UVA, the endothelium is not damaged. Of course, with the rider here, that adequate UV irradiation of about irradiance of about 5.4 joules should be maintained, and the corneal thickness should not be more than 400 microns. Now, as rightly Madangi said, that we know that around 25% of the patients would be having CCT less than 400 microns. So Hafezi et al., they developed this protocol to include that, to widen this eligibility criteria for patients who are having CCT, having corneal thickness of less than 400 microns. And they hence put forth this sub 400 protocol. So for this, they mainly worked around the exposure time, as per the Bunsen's principle, that the total fluence, if it is standard, the photochemical effect would be the same. So here they played around the exposure time to achieve the chemical biochemical effect in the post CXL cases. So by varying the exposure time, in this particular group of patients, what we could see was as little as thin as 214 microns to as up to 400 micron patients were included. And so for around 214 microns, I think the irradiation time was just 1 minute, and around 29 minutes for patients with 400 microns. So this was the basis of the study. However, what I see, the major limitation remains that the post-treatment evaluation of endothelium, the study is silent on that. Though the study was designed to prevent the irradiation induced endothelial damage on the endothelium, but the post treatment evaluation of the speculum through a specular microscope or any other technique has not been provided by the authors. And also it was a retrospective study, so that implies that the procedure was being done before the start of the study. And it translates to the fact that it could have been a non-homogeneous group, particularly with reference to the age, comorbidities like VKC, which could have been present in some patients, and also the severity of keratoconus, and the post-exposure treatment, which have been variable in such cases. So, and one thing also, that they have included patients more than 30 years of age, going up to the 40 years. So stabilization of disease in this group of patients could have been age-related also. Further, in some patients in this age group, they might have be having diabetes mellitus, which could also be a confounding factor. Understanding that diabetes also can induce some sort of a cross-linking by the process of metabolic glycation. So, and there's no mention of VKC or any other comorbidity in the young adolescent age group of about 9 to 19 years, which could be function as both as a predisposition and a prognostic indicator. Uh, so I believe that this study, though, is a very great effort by the authors, but it definitely requires further validation by prospective trials with, of course, a homogeneous group for a longer duration, because we are aware that the corneal biomechanical structure and cellularity changes at least in several studies. It has been documented by up to 36 months. So here the duration of the study, the findings have been stated only at 12 months. So that was from my side, and I would open the discussion to our esteemed panelists.
Satyamurthy, sir, your take on this. And sir, you are muted. Sir, you are muted.
Yeah, now you can hear me?
Yes, sir. Yes, sir.
Okay, fine. A very nice study and a nice presentation also. And Madam very aptly, she summarized the whole thing. So one thing is, of course, retrospectively they have studied this, but the nomogram, it will definitely help a lot of patients with lesser corneal thickness. No, as said, endothelial decomposition, endothelial integrity. If in case if it is if it was objectively studied, probably it would have been better. But still, we can definitely make use of this. My only thing is, instead of doing the regular procedure, can we use pulse therapy in this, associate with this, so that oxygenation would be better? See, that is the main thing, isn't it? Once we start using riboflavin, the oxygen concentration starts coming down, and especially in the posterior part of the cornea. Otherwise, everything else is fine. And the limitations were also nicely discussed. So I don't think there's anything else from my side. I think,
Thank you,
sir.
sir.
Yeah, fine.
Okay. Srinivas, sir.
I think, yeah, much of it has been said already. I personally use the protocol. So there's the thinnest cornea I've done is 220 microns in a keratoglobus child after talking to aphasia. And the cornea has remained okay. But that's not really classically a progressive disease. We just did it to strengthen the cornea. But we have used it in thinner corneas and keratoconus in whom we were previously unable to help, 350 and below, when we couldn't use the hypertonic and so on. So as proof of concept, I think the study works well. It's a paradigm shift because everything before this, we were using the reciprocity law So even in the accelerated protocols, basically we wanted to deliver the 5.4 joules. So if you reduce the, the duration, the irradiation went up. So he kind of changed it now, basically saying that the overall radiation is less because you're using 3 milliwatts per centimeter square. You're not using it for 30 minutes. You're using it for 15, 14, 13, whatever. So therefore, the amount of energy you deliver is less. And therefore, he says it is safer for the thinner corneas. Kind of makes sense. But I agree that 1 year is a little bit too, I mean, it's not long enough to, completely understand the long-term effects of this procedure. Because with the standard protocols, now that we've been doing it for a long time, I see continued flattening at even at 7 years. So you get a cone, it just keeps going down, 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 down. That's like we used to see in the old RK patients. And in some of the patients, we see worrisome loss of corneal integrity. There's little areas of lucency in the central cornea. It looks like a optically lucent area. If you do an OCT, you'll see an empty space, optically empty space. It's nothing there. And these people can melt and go into a decimeter seal, and you'll have to operate on them, do a tectonic procedure. So when you're treating a thinner cornea, these are definite concerns. And again, the specular issue has been highlighted as well. So as proof of concept, it works. But I agree that you probably need a longer follow-up of these patients before we can, conclude. But like Dr. Satyamurthy mentioned, at least it gives us an option in these thinner corneas in whom before we didn't have anything to offer.
Thank you, sir. Dr. Himanshu sir, two questions just for you. One is uh, regarding the study, and another one is what are the various options available for the as a treatment, because lots of PGs are watching it, so they wish to know what is the various options for the thinner corneas apart from this study.
So
Sir.
basically, Hafizi has come out with something which we always wanted to know, that can be how thin we can go, and it's always nice. When we talk about treating the keratoconus, when we treat with cross-linking, we're concerned about one safety part of it, that we don't want to fry the cornea, we don't want to damage the endothelium. And second part, we are concerned about the effectiveness part of the treatment, whether treatment is doing what it's supposed to do, right? So safety, which is affecting the endothelium, as well as the scarring and haze which it leads to. And on the other part, we are talking about the effectiveness, right? So when we have a treatment which immediate safety values, as in it has not hit the endothelium, it has not led to significant amount of increased corneal thickness or corneal edema, which may be an indirect way to tell us that it's not frying the endothelium, it's not damaging the endothelium. However, if we want to know effect on the endothelium, of course, specular microscopy needs to be done. But we remember the specular microscopy, anything what happens, it's a long-term thing. Now, if you damage an endothelium, the specular microscopy is not going to change immediately, because a damaged endothelium cell is replaced by surrounding cell, increasing in the size of individual cell, and thus densitometry, or rather the density of endothelium in per square millimeter scale, reduces. So it takes time. Now, initial period when we have damage on endothelium, which would be shown as altered corneal thickness or the corneal edema, Descemet folds, and all those things. So they didn't show those kind of things. So at least hopefully, whatever from whatever they said, it's safe as per whatever the protocol Dr. Farhad Hafizi used. In terms of what Dr. Eskera was talking about, the haze part of it and scarring part of it, which we all know takes a little longer time. And as all the previous speakers spoke, that we need to wait for longer term, especially when we are using Dresden protocol 3 milliwatt treatment, which usually does over treatment than what. Now, lately, we all have been, so when we talk about treating thinner cornea, there are three parts which we actually take into account. One is irradiation part. So either we reduce the time, by what Farhad Hafizi showed here, keeping the fluence stable, which is 3 milliwatt here, what they've used. or we can increase the fluence. Now that's accelerated cross-linking. Now, though, if you look at the calculation part, total energy delivered may be same. But we all know that when we use an accelerated cross-linking, the treatment delivered starts becoming shallower and shallower. So if we are treating with 3 milliwatt per for 30 minutes, the treatment is much deeper, or the effect of cross-linking is much deeper, versus when you are using something like 18 milliwatts for 5 minutes, where the treatment is much shallower. Now, it's very debatable to know whether that this thing works or that thing works. Most of us have reverted, or most of us have rather have changed over to accelerated cross-linking, and it's there to stay, and very few are continuing with 3 milliwatt. So accelerated part does reduce the depth of the treatment and makes little thinner cornea more amenable to treatment. So that's one part of it. Second part, Dr. Hafizi is talking about reducing the time part. The other part where we can touch upon in case of low corneal thickness cross-linking is changing the riboflavin. Now, earlier they used to use riboflavin with dextran, which used to reduce the corneal thickness. We shifted from dextran to something like HPMC, though isotonic, but HPMC treatment, which increases in most of our hands. It increases the corneal thickness, intraoperative corneal thickness, by almost 80 microns to 100 microns. Now that again makes some of these cornea treatable, which were earlier thought of not treatable. The other part which a lot of people reported was putting barriers by increasing the corneal thickness. So by adding something like contact lens or a lenticule on the surface, which pushes the endothelium much away from the surface, and hence possibly saving the endothelium. But we also know that majority of the treatment of cross-linking occurs anteriorly. So by putting any extra barrier, we really don't know how useful or how much effect of the cross-linking would come there. On the same time, when we talk about effectiveness of cross-linking, we are still blind. We still believe that demarcation line and all those things are mandatory. All we know now that is that there is a haze, or there is a demarcation line which we see. Now, whether it's overfrying the cornea or whether it's required, we really don't know. So all those things possibly we would come to know when we have a larger trial, also including not just Dresden protocol, but accelerated protocol also, which commonly is used. Now, it's very interesting that they use hypotonic riboflavin, but they did not mention the change in the corneal thickness in individual cases and how much corneal thickness was changed. And then when they started irradiation, what was the pachymetry at that point of time? So it certainly would have helped us that if they had mentioned about the change in pachymetry after soaking. High failure rate of 10% can be justified by saying that they took cases which were a little severe, but I think my all colleagues here would agree with me that these do not seem to be as severe as many of the cases which we treat in terms of curvature, in terms of corneal thickness also. So along with this thing, one important part which they missed out was what Demin Gatinel and his group spoke about, the risk factor of eye rubbing, direct and indirect eye rubbing, and more importantly, indirect eye rubbing. If we do not consider those part, then possibly we may take away the credit of the entire treatment by not paying attention to those indirect eye rubbers, which they might continue doing. And we may say that treatment does not work. Overall, it's a wonderful study which does tell us that, you know what, we will be able to come to a number which can be possibly considered in future. But as Dr. Satyamurthy and Dr. Rao said, we need larger studies. We need a more comprehensive study. We need groups which are more homogeneous group, as we can see from here, which is not. But overall, yeah, it's certainly a direction towards in the future where we would be treating much more thinner corneas.
Thank you, sir. Once again, thank you for all the three experts for giving us the wonderful tips what is lacking in this, despite of the wonderful summary by the Bhavna ma'am. Our next journal club is on the ODAK trial on acanthamoeba keratitis, and it will be presented by Dr. Reddy, and his mentor is Dr. Parinita Sahai. Dr. Reddy, please.
Good evening, everyone. Is my screen visible?
Yes, visible.
Good evening. I'm Dr. Gahan Reddy from Guru Nanak Eye Center, MAMC, and my mentor is Dr. Pranita Sahai ma'am from Guru Nanak Eye Center. And I'll be presenting the orphan drug for acanthamoeba keratitis, or the ODAK trial, which was done by Dart et al. And which compares PHMB 0.08% polyhexanide and placebo versus PHMB 0.02% and propamidine 0.1% as the control group. So this is the study. So acanthamoeba keratitis, a little background, it is less common and it has variable clinical presentation, and it can be confused with viral or herpetic keratitis in the early stages. The microbial tests have low sensitivity and the culture has only a positivity rate of 50%. The patients need a prolonged treatment because the cysts are resistant to treatment, and there is no single proven effective drug yet available for acanthamoeba keratitis. There is limited drug availability of the drugs which are proven to help also, and also there is no definitive treatment algorithm. So this study was designed to benefit all these problems. So the ethics approval was taken and informed consent was taken, and the study was conducted according to the Declaration of Helsinki. It was a prospective, randomized, double-masked, active control, multi-center phase 3 trial. There were three centers in the United Kingdom, 2 in Italy, and 1 in Poland. And the study period was from August 2017 to June 2021. So the study included any patients of acanthamoeba keratitis greater than 12 years of age who had clinical findings consistent with acanthamoeba keratitis, who had in vivo confocal microscopy findings consistent with acanthamoeba keratitis. And interestingly, they did not include PCR or culture positivity as a definite criteria for inclusion. But if patients were positive in IVCM but were negative in PCR, the IVCM was again reviewed by an expert. And if then found to be negative, then they were removed from the final analysis. The exclusion criteria included patients who were pregnant or planning pregnancy, who had concomitant viral fungal keratitis because this would be confounding factors, prior treatment with acanthamoeba drugs, systemic immunosuppressive therapy, or those requiring urgent surgery. So there were two treatment arms, arm 1 and arm 2. The arm 1 was topical PHMB 0.08% monotherapy with placebo, which will be referring as high dose PHMB. The arm 2 had PHMB 0.02% with propamidine 0.1%. We'll be referring to this arm as PHMB plus group. Both the placebo and propamidine had the same concentration as of preservative, BAC 0.05%. So at the initial entry, an intensive 19-day anti-amoebic treatment was given with 1 hourly drug drop given for 5 days, then 2 hourly for 7 days, 3 hourly for 3 days, and then QID continued thereafter till treatment. So this is the consort diagram for this trial. It enrollment, allocation, analysis, randomization, and the follow-up protocol. So 135 patients were assessed and 135 were randomized. Computer-generated block randomization was used, and then 69 were allocated to high-dose PHMB group, and 65 were allocated to PHMB plus group. In the final analysis, 62 were included as some patients deviated from the protocol in the PHMB high-dose group and 57 in the PHMB plus group. The patients were asked to visit pre-op at 1 week, 2 weeks, 3 weeks, and 30 days thereafter until treatment. And they were finally seen 90 days after stopping the drug to confirm treatment. So the definitions used in the study is that they gave a staging for acanthamoeba keratitis. The stage 1 was only corneal epitheliopathy. This could be easily confused with herpetic disease. Stage 2 was corneal epithelial defects, perineural infiltrates or stromal infiltrate. Stage 3 was corneal ring infiltrate or corneal abscess. Cure was defined as no epidefect or infiltrate after cessation of treatment for 30 days, but this was reassessed at 90 days and then confirmed. Medical cure rate is the rate of cure by each treatment without the need for surgery or the change of anti-amoebic therapy. Treatment failure was defined as treatment being needed for 12 months without resolution, alternate anti-amoebic therapy needed, or need for immunosuppressive therapy, surgery which was needed, or any adverse drug event for which the treatment had to be stopped. So the investigations performed by this group were comprehensive history and slit lamp examination on every visit, IVCM for baseline visit diagnosis, PCR and fungal culture at baseline visit, cell lines visual acuity every visit, Eurocall 5-dimension, 5-level visual analog score for at the end of study, and 25-item visual functional quality index at the end of study. These two are patient-determined scores which show how the patient perceives his or her health to be in the terms of quality of life in 5 dimensions, which include self-care, motility, depression, and pain, etc. And also on 25 visual questions, which show how the patient is doing visually, whether he can move about on his own, or whether he can read books on his own, etc. So the primary outcome was the medical cure rate within 12 months. The secondary outcome was the best corrected visual acuity, the corneal scarring rates, the treatment failure rates, Eurocall 5-dimension 5-level health questionnaire, 25-item visual functional questionnaire. So the statistical analysis used was SAS software version 9.4 was used, and also Stata software was used. Kaplan-Meier curves were drawn for time to endpoint analysis, and they were adjusted for covariates using the Cox proportional hazards model. So this flowchart shows how the patients were followed up. The blue part shows how the patient was, if the patient was doing fine and the patient was improving, then the treatment was discontinued and the patient was visited every 30 days. And if at 90 days the patient had no symptoms, then the patient was successfully treated. And the red shows where the patient has relapsed or the patient needs anti-inflammatory treatment or any surgery, and therefore would go to treatment failure. These were the two outcomes of the study. So this shows the baseline demographics and the clinical status of the 127 participants. The authors did not include the p-value to show the difference between the two groups, so it could not be directly commented whether they were comparable. But they were mostly comparable except for gross differences and in the disease staging at baseline. So the PHMB, high dose PHMB group had 16.7% of the patients who were at stage 3, and the PHMB plus propamidine group had only 11.5% of the patients in stage 3. And also bilateral disease with scleritis was present in 15.4% of the patients in PHMB high dose group and only in 6.6% of patients in PHMB plus, which overall shows that more severe patients were included in the only PHMB high dose group. So the primary outcome, which was the medical cure rate, at 12 months, it is shown that both PHMB plus and high dose PHMB group had a medical cure rate of about 84 to 88%, and the p-value was 0.6, so it's not significant. Both of them were effective. And after adjusting for confounding factors, even then they had a adjusted efficacy of 86%, and the p-value was still insignificant. These confounding factors included the prior anti-amoebic therapy or prior antifungal therapy, or if they had any systemic conditions, also the stage of the disease. So the secondary outcome measures which were included the visual acuity, corneal scarring, treatment failures, and the visual quality of life indices. Even in this, the patients did not show any significant differences and all the p-values were insignificant. Also interestingly, the corneal scarring at the end of study showed that 50% of both groups had no corneal scarring, which does not translate to our population where we have severe cases and most of our patients end up with scarring and needing pediatric keratoplasty. Also, the visual acuity was given in Snellen's chart, and it's difficult to analyze it, and it should have better been given in Logmark chart. So this chart shows the Kaplan-Meier time to cure plot analysis, which shows that the PHME plus propamidine group had a 50% cure rate in 119 days, but the PHME high dose group had a delayed 50% cure rate of 146 days. This can also mean that the patients who were included in PHME high dose group were severe, as we've seen before. So maybe they had a delayed cure rate. But after the confounding factors such as the stage of the disease, prior antibiotic or antiviral use were taken into consideration, the Cox proportional hazards regression show almost similar curve, which showing that 50% of both the groups patients had been cured by 122 to 126 days. So the safety outcomes were measured, and there were no serious adverse effects in both groups, but 40% of the patients in both groups, and which p-value was insignificant, or had minor adverse effects, which included redness, itching, and irritation. This shows the various staging. The first photo is only epitheliopathy. The second photo showing perineural infiltrates. Both of them healed without scarring. The third shows stromal infiltrate, and the fourth also shows stromal infiltrate, which have minimal scarring. These are ring abscesses which healed with scarring. So the study concluded that PHMB high dose 0.08% monotherapy is not inferior, although not more effective than the dual therapy comparator, and no significant toxicity on either sides were noted. Thus, single drug therapy is proven to be non-inferior, and because it ensures increased compliance, should be preferable. This study showed a higher success rate than other studies, which can also be due to the less severe cases which were included in this population. The limitations of the study that it had a small sample size, and there was no direct proof of better drug penetration with higher concentration. When the authors studied the amount of drug in the anterior chamber, they found there was no penetration in either group, even on increasing the dose. So the less severe cases were also not representative of the Indian scenario, and also both the groups were not properly matched because the severity was not matched. Thank you.
Thank you, Dr. Reddy, for the wonderful presentation. Dr. Pranita, can you summarize, please?
Yes, sir. First of all, I would like to congratulate Gahan. He is a second-year postgraduate, and to present a prospective RCT with so many tables and so many analysis and be able to actually project it well to the audience is something commendable. So thank you again for presenting it so really well. And coming back to the topic, so acanthamoeba keratitis something is a really interesting topic. Whenever you see a patient of acanthamoeba, the first thing, the diagnostic dilemma, you're not able to prove whether it is, you clinically know it is acanthamoeba, but to translate it, to be able to diagnose it based on the confocal and the investigation is difficult. And then the treatment drug availability is always a challenge. PHMB is not usually always available. Promamidine is not always available. And combination therapy is something that we need to give to all these patients. And this study giving a high dose PHMB, if this drug really gets an approval and comes into a market, it will something that will be really beneficial for the cornea specialist. So I think that makes this study really important because this is a phase 3 trial for the high dose PHMB, which may in future translate it to be available in the market for us to use. But there are a few concerns that he rightly pointed out. First, that it is a sponsored study, and the same pharmaceutical company which is propagating this drug in the market has sponsored this study. So that can be one of the factors that can affect or bias the study towards a positive result for the same drug that is being marketed. That is one of the concerns. And second, that obviously the severity grades were not equally matched. The baseline characteristics for which a p-value could have been suggested to show that the baseline groups are equally matched could have been better projected in the baseline characteristics. But if really this result can be translated in subsequent studies with similar results, I think it's going to be a landmark study that can help all of us cornea specialists in management of acanthamoeba keratitis.
Thank you, Dr. Pranita. Dr. Srinivas, sir, first,
Yeah, I
your
think,
comment on it.
yeah, John Dart has been working on this area for a very long time. So I'm quite impressed. He must be quite in the 70s now. So he's the lead author on this paper. So that should tell the PGs something. So if you have a passion, you continue to work on it. Yeah, I think it's okay, but it's a non-inferior result, basically. So, you're just saying that I can add this strength and then it is not worse than the existing option. So you need to take that in consideration. So what we're really looking at is a better option to treat our patients. You already have an existing option. Now you're saying that I have something else that is as good as, probably not worse than this. So that should be taken with a pinch of salt. And the second thing I'm concerned about is the toxicity. Even with 0.02%, when you use it prolonged, which is how it goes in an acanthamoeba, you have to use it for fairly long periods of time. Toxicity is a concern. So 0.08%, basically, I would be really concerned about toxicity, although they did not find too much of it in their study. Maybe when it is formulated as a proper medication, rather than how we do it when we just dilute it from existing commercial sources, it may be a little better. But for me, it is something that I will sit and wait and watch because my 0.02% works fairly well for me at the moment. It is cysticidal, results are pretty good. And they've not really shown the desperate kind of cases in whom the 0.02 doesn't work, in whom escalating to 0.08 would therefore, improve your outcomes. So it is something interesting to keep an eye out for, but it's not really earth-shattering for me at the moment.
Satyamurthy, sir.
No, first I should congratulate the person who has conducted this study because there's so many cases of acanthamoeba keratitis. Very difficult to find that many. So I don't agree with that. It was a small sample size, and then see that's what I was worried about the toxicity part of higher strength PHMB, which was not properly discussed. I mean, just the article says, okay, there was no difference between the thing. Probably as the mentor said, it's biased towards this. There's a bias actually, and then the frequency part of it. Say higher strength, probably you reduce the frequency. I mean, a reduced frequency probably will help further. Otherwise, we'll just sit and watch, like Dr. Rao said. Since 0.02% with propamidine is working very well, I don't see any. Yeah, I mean, the reason why we should change the thing. Um, and then the type of cases they have shown, they're very in the very early stage patients, but we see patients who come at the very late stage. Like it was presented, most of them will end up with a scar. So that kind of situation we see. They take all sorts of treatment and come to us. So these cases where 0.02% has failed, whether your higher strength PHM is going to work or not, so that we'll have to find out. Probably Indian study would be better in a scenario like this. But all said and done, it's a very good study. Probably that opens up a lot of avenues for further improving the treatment. Yeah, thank you.
Thank you, sir.
Yeah.
So Himanshu sir, Satmurthy sir given you one option to plan a much bigger and better study than it. But before it,
I think one
I
thing
would
we
request
have to
for your comments.
we have to understand and agree that the incidence of acanthamoeba keratitis is nowhere close to what is there in those countries where the study was performed. One possibility that our diagnostic capability are not as great as them, and we are not able to detect them early. But to get as many number of cases as they got and to do a randomized control trial is not a joke. I mean, it's a commendable thing, and it's a very sizable number for such kind of disease. So that's quite amazing. Now, when we talk about acanthamoeba keratitis, as Dr. Rao pointed out, that well, we wanted something else because what we have is antiseptics. We do not have anything which is specific against either trophozoites or cyst. So we are trying to put something which is in general killing everything, and in that whatever gets killed. So when we use such kind of thing, the first thing which comes to our mind is toxicity part, the collateral damage which the other tissue gets. Hence, the previous studies, whatever were done, ex vivo studies on keratocytes and on all those things, were important to know that the drug toxicity part of it. And that's the reason why 0.02% was like finally 0.002% was finally thought of that, okay, you know what, this is something which works. Now, we want to keep it on the lower side to reduce the drug toxicity. But at the same time, when we have a disease like this thing where specific treatment is not available, you may want to go on little higher concentration also. So when you change the concentration, we would be concerned about the drug toxicity part. Now, this study actually showed that it's not as toxic as we thought, that by changing the concentration, by increasing the concentration, it was not significantly surface toxic. Also, previously, whatever ex vivo studies, and we know that cysticidal concentration was almost 10 times more than the troposidal concentration which we need. So again, I exactly don't remember, but one of the Korean group had done the ex vivo studies, and they had shown the cysticidal concentration was like almost 4 to 10 microgram per ml, which is like 0.004% to 0.001%, which is more than what we use as a troposidal concentration. So certainly this concentration may help us in a better outcome. A monotherapy in a microbial keratitis, if it works, can definitely be better than a multi-drug therapy, because two drugs which are prepared, which are not commercially available, we are looking at quite a significant amount of irregularity there, whether it's composition, whether it's stability, whether it's sterility, many other things too. So I would certainly be happy if we have some of this kind of drug available to our market. Clinical relevance, how it would be, well, the incidence of the disease is not that high, so it may not be earth shattering, but it's certainly welcome where we have something where we possibly can have not inferior outcome and not significantly increase drug toxicity levels.
Thank you, sir. Sir, before we close the session, first, Srinivas sir, your comments on the young PGs who presented so well. Just one or two line of appreciation from your side.
I'm amazed by the increase in the quality of the presentations. When we started, people were very nervous. And in my days, I'm talking about 30, 35 years ago, presentation was, such a scary thing. But I'm quite amazed by the confidence with which everybody presents today. I think this is thanks in no small part to the efforts that the ARC and the AIOS has made, giving everybody an opportunity to present. So, and the depth of knowledge that goes into these presentations and the confidence with which they're presenting, it's wonderful and laudable. So congrats to both the presenters and to the platform, which is giving them an opportunity to do this. So wonderful. I'm quite impressed.
Satyamurthy sir, you are
Yes.
yourself as a wonderful mentor. So few lines for our today mentor, Dr. Bhavana ma'am and Dr. Pranita.
Right. No, of course, mentors, they're excellent. I mean, they know the actual thing. I mean, what exactly, how they should guide their students. So it will definitely help. And then, I mean, I congratulate the students also who presented this. It was an excellent presentation. Like Dr. Rao said, so now present students are much better. Their understanding is much better. Only my appeal to them is just continue this research work wherever they go, and then just come out with something like this for the future generations. It'll definitely help. Thank you.
Dr. Himanshu, you are a wonderful teacher on the soft skill and how to present. Even in the midterm, your lecture was fantastic.
Thank you.
Just 2-3
Thank
tips
you.
to our young generation, how to move or how to present or make presentation better, something like that.
I think they are pros. I don't think they need any support or any suggestion. I'll just tell you one thing, that this is an opportunity which you get, which not many of you would get. So use it possibly for the future presenter, use it to the max. You really don't just want to present a concise, summarized article, which is there for everybody to read. You would rather present everything, smaller nuances, point out things which are not properly done, methodology, show them how to analyze the article, and possibly, and you know what, if you have question, reach out to the authors, find out from them if they can, and many times you would be surprised, they do respond to your queries, that you know what, why I did this thing and something. So when you have your chance to present, I would say excellent presentation, crisp presentation is one side. Do something more, go beyond and analyze the thing, and just go that possibly this is your one chance where you can go beyond the presentation.
Bhavana ma'am, you supported ARC at least I think 3-4 times in this session too. I would like to hear a few words from your side.
Yes, Deepak, it was an absolute pleasure to be here at least 3 to 4 times, as you said. And I'm very thankful to ARC for such novel and nice initiative that is giving a platform to our postgraduate students at the national level and national forum. So from Madhu's preparation, I can see that she was constantly coming to me for last 1 week. They treat it so seriously. They know that actually they're, at the national forum. So they prepared it befitting the standards. So that is why they study more and put in a lot of effort. So I'm thankful that ARC is giving them the platform, which is very, very motivating also, to work for more and to work for betterment. And that is all my appreciation for the team ARC and AIOS for taking up these novel initiatives. And I also thank Dr. Matalia's such nice comments to go beyond their presentations, and Sirs SKR, sirs, of course, he's always a big motivator, and Satyamurthy sir, thank you all.
Thank you. Thank you, ma'am. Dr. Pranita, you are in the mid of the faculty, means someone is very senior like Srinivas sir, and you have started your journey 5-6 years back. So
Yes.
what change you will see, or what you suggest nowadays presentation from the previous set of your time?
I think first of all, I'd like to thank all of you for this opportunity that at this young age, you have given me this platform to be a mentor. Just a few years back, I have been presenting as a senior resident and a postgraduate, and suddenly turning into a mentor. I have been running around my PG that, okay, don't make this mistake. Okay, this has to be perfect. It's such a huge responsibility to be a mentor. It's easier to be a student than to be a mentor. And that's the first change. And yes, I think there's been a lot of change. The quality of presentation has definitely changed. While when we used to present, the formatting, the animation, the presentation, the analysis, and we would probably read out the slides, and they are so confidently, without much of text content in the slides, are able to narrate things so really well. I feel so proud of my PG. So he's been being able to do that so really well. So that's all from my side.
Thank you. Dr. Mathangi and Dr. Gagan, for you, what I can say, you people do wonderful, and presenting a case in presence of the ophthalmic and refractive or corneal ligands like Srinivas, Dr. Himanshu and Dr. Satyamurthy itself is a big prize. I only say it, and in few course of time or in future, when you listen them as presenting or their topic or faculty talk, then you realize, or it will be a great to have experts like him, and the good word from them for you is really a blessing for you all. Only thing I can say. And once again, thanks from the team ARC, both the mentors, Bhavana ma'am and Dr. Pranita, and with my folded hand, Srinivas sir, Satyamurthy sir, and Himanshu sir. Thanks a lot. Thanks from the bottom of my heart for giving your precious time and guiding these young budding ophthalmologists. Thank you, everyone. Thanks a lot.
Thank you, Dr. Deepak. Thank you. Thank you. Nice.
Thank